Good morning, students. In the previous video, we studied about the kinematics of elbow joint, and we studied the range of motion of elbow joint, and we basically studied how the motion was taking place. That means when the elbow flexion was taking place, we have to define that motion, that when the forearm muscles or when the forearm bones move towards the or moves anteriorly towards the arm, that is flexion, elbow flexion. Herein you understand the distal articular surfaces or distal articular bones are moving towards the proximal articular bones. Fine. So you have to first herein tell me this is the motion. Since it's a modified, we are telling is the motion. This is a elbow flexion motion. So elbow flexion motion is taking place in the sagittal plane as well as in the axis. Okay, this is the flexion and extension motion. You have to tell me this plane. You have to also tell me this what is the motion which is happening herein. The forearm or the hand, or the forearm and the wrist and hand is moving towards the arm and the shoulder. Fine. This is called as elbow flexion when the forearm and the wrist and hand is moving away from the arm or from the shoulder. That is called as extension. So you have to tell me the plane of motion and plus the axis of motion, the range of motion, which is 135 to 145 degree of elbow flexion is taking place. 0 to 145 degree of elbow flexion is taking place. You have to tell me the range, the plane, the axis. The motion need to be defined. We have already discussed about the muscles, that is the flexors, how the flexors, that is biceps, brachialis and brachioradialis, how they are acting, and how the triceps and inconius are acting and producing this movement. Fine. We have also studied the structures, the active and the passive structures which limit the elbow flexion and limit the valgus and the varus stress, and the role of collateral ligaments as well as the joint capsule, how they have been stretched. You need to tell me about that also. Fine. So what these are about the osteo movements, that is the bony movements. Now if you have to tell me about the arthro movements, you need to tell very simple thing is that the if you can see this already discussed, these are all the convex part. The proximal articular surface is both the capitulum as well as the trochlear is basically a convex surface. It is a basically convex, and the head, the olignin, the trochlear notch or the trochlear notch is a concave, whereas the head is also concave. So what is happening over here is the motion is, if I can say, the concave bones of the forearm or the head of the ulna and the radius is moving on the convex stable surface. So that means the arthrokinematics is similar to that of the osteokinematics. You have to tell me in this form, that is the rolling and the gliding will take place in the same direction as when the as the bone is moving. Herein you can see that when the elbow flexion is taking place, the rolling is the head, or the, if I can say, the head as well as the forearm is moving posteriorly. That is, the forearm bones are moving posteriorly. So there is a movement of posterior roll and glide is taking place, whereas when the elbow extension is taking place, the forearm bones is moving anteriorly, and there is the movement inside the joint will also be rolling will be anterior as well as spinning will be anterior. You have to mention this in the kinematics of the elbow joint. Now let us start with the superior radioulnar joint. Fine. The superior radioulnar joint I have already described little bit about the articular surface. Now let us see this again. You see this is basically the trochlea and the trochlear notch. Just below the trochlear notch, let me show you over here. Yes, this is the trochlea. You have understood. This is the ridge, trochlear ridge. This is the trochlear notch. This is the olignan process, and this is basically the coronoid process. Here you see a facet where the head of the, if I can show you properly. Yes, here this is the facet. Now this facet is basically, you can see, is this is a facet, and this is basically a concave facet is there. This is a concave facet. Fine. And this is called as the radial notch. You can see over here the radial notch is there, and the radial notch is where the head will go and sit. This is how the head. So here the head is, you can see, a convex structure, whereas the radial notch is a concave structure. It is a concave structure. Fine. The notch is the concave structure, whereas the head is the convex structure. Fine. So here is the notch, and here you also see another structure is called as the annular ligament. Basically to place, this is the articular surface. You can see it is the radial notch on the ulna and the convex surface or the head of the radius. They become the part of they are the articular surface of the superior radio-ulnar joint. They become the superior radio-ulnar joint. So you can see how it is moving. It is this. Now to secure this position, there is an annular ligament. It is basically a ring-like structure which is holding this joint. This is a ring-like structure which is holding this joint. Fine. So this is basically in this form. Let me hold like this only, then only you can see it properly. Fine. So this is basically a ring-like structure is holding it. Fine. So that is called as the annular ligament. So there is a radial notch, there is a radial head. Fine. So the articular surface is the radial notch, the annular ligament, and the head of the radius. There is a concave, we have seen the radial notch which articulates with the convex radial head. The range of motion at this joint is supination and pronation. Now supination and pronation takes place as transverse plane and vertical axis. I think you guys already know. Fine, you need to tell me the plane, and this is basically you have to tell me the kind of joint it is. It is a kind of a pivot joint. Fine. So it is allowing only 1 degree of movement, that is supination and pronation. So degree of movement is also important over here. It is allowing us only 1 degree of motion. So the supination, during supination, the convex radial head will move on the concave radial notch. So the sliding of the head of radius is opposite to that of the in opposite direction. That means here the arthrokinematics will be opposite to that of the osteokinematics. In the elbow joint, we saw that the arthro was same as that of the osteokinematics. Fine. Now if we see these are the two bones, we see the structures. Now first structure to be seen over here is, are you able to see? No. Let me show you in this form then, because I am able to see it like this. So can you see, this is the notch, this is the head, this is the notch, radial notch, and this is the head, and this is the fossa. Now this is the structure. You can see over here the A part. Now in A part you can also see this is the annular ligament, this is the annular ligament, this is the part. The first ligament, there are 3 ligaments which are holding this superior radio-ulnar joint. One is the annular ligament which is holding the head. The second one is the quadrate ligament. This is arising from this radial notch, the upper part of the radial notch, and going up till the neck. I'm just giving like this. You can see it is arising from this radial notch and going up till the neck. This is the neck. And you see, this is the neck. It is holding it in this form. It is moving like this. It is in this form. That is, it is coming from here and going over there. So that means at the coming from the radial notch and going up to the neck of the radius. So this is the quadrate ligament. There is another ligament which is going again from the radial notch, and it is going up to the radial. This is the tuberosity, radial tuberosity. Can you see, from the notch it is going up to the radial tuberosity. That's called as oblique cord. This is called oblique cord, and if I can put that back again, you can see these 2 bones are held together. These 2 bones are held together by a ligament which runs and which holds or a membrane which holds the 2 bones together, and that is called as interosseous membrane. Fine. Now let us read through these ligaments. The ligaments are 3 ligaments associated in the proximal radio-ulnar joint, and that are annular ligament, quadrate ligament, and the oblique cord. The annular ligament is strong and it encircles the radial head. The quadrate ligament is it extends from the inferior edge of the radial notch to attach to the neck of the radius. It helps in maintaining the head in opposition to the radial notch. That is, it helps in the joint stability, and it also helps for the spinning movement, allows little bit of spinning movement of the radial head. So this quadrate ligament is very much responsible for the spinning movement in supination and pronation. Fine. And there is an oblique cord which extends from the radial notch and goes up to the bicep or the radial, not here, the radial tuberosity. Fine. And there is it is radial over here. Fine. Then there is an interosseous membrane which is shown extending between the radius and the ulna, and this is basically preventing the separation of radius and ulna. Fine. Now let us see what are if this is the one. Now let us see the inferior part. Now let us see this, the inferior part, the inferior radial ulnar joint. Now if you can see the inferior radial ulnar joint, this is the inferior radio ulnar joint, where the radial side is more as compared to the medial side. The radial side you can see and the medial side. Fine. The radial styloid process and the medial or the radial styloid and the ulnar styloid process. You can see this. Fine. Can you see? There is a difference again here. So it is formed between here. This is a let me color this again so that you can see it well. This is the ulnar notch of radius. This is the ulnar notch of radius, and it is attaching with the now it is attaching. Yes, it is attaching with the convex or the head of the ulna. It is attaching with the head of the ulna. It is little bit convex. Now this surface is little bit convex. This surface. Yes, this is the ulnar notch of radius, and this is the head of the ulna. So how it is attaching? It is attaching in this form. It is attaching in this form. Okay. So that is it is again the concave surface of the radius is moving on the there is a convex head of the ulna, and there is a disc in between which is called as the articular disc. So there is a concave ulnar notch of the radius articulate with the convex ulnar head. So there is a disc which is called as articular disc, which is also called as the triangular fibrocartilageous cartilage complex. It is called as TFCC. Now this is basically an articular disc, because there is, you can understand, it is again it is for the stability of this joint. There is a requirement of a triangular structure. There is a requirement of a triangular fibrous and a cartilaginous structure. And why it is said to be a triangle? Because I'll show you from the inferior side. Can you see? This is the inferior side. And this is very much important, because this triangular fibrocartilaginous complex we will be studying in the it is not only acting as an articular disc for the distal radio ulnar joint, but it is also acting as a barrier, or it is a barrier between the next are the carpal bones, that is the distal radio ulnar joint, and the proximal carpal bones, that is. So it is also acting a disc over there. So in the next picture you will be able to see this is the same image as the image over there. Now you can see this process is the radial styloid process. This is the ulnar styloid process. You can see the ulnar and radial. This disc is basically a triangular structure. That means it is arising from the ulnar styloid process. It is arising from here. It is arising from here and giving a branch up and a branch down. That is, it's a triangular disc which is arising from the ulnar styloid process, and it is moving up as well as moving down, and it is giving two ligaments. One is the dorso-radio-ulnar ligament and another is the palmar radio-ulnar ligament. It is a triangular fibrocartilaginous complex which is giving two ligaments, the dorsal as well as the palmar radio-ulnar ligaments. This is another view of this. You can see how it is attaching to the ulnar styloid process, and why it is said to be a triangular surface. Now if it is attaching from the ulnar styloid process, it is just covering this notch. It is just covering and you can see the ulnar notch. It is of the radius. It is just covering the ulnar notch of the radius. So that is why it is known as the triangular. That is arising from the ulnar styloid process and it's covering the ulnar notch, gives a triangular shape. That is why it's called as triangular fibrocartilaginous complex or an articular disc. Its importance is there. Fine. So we will be just studying this importance in detail in wrist complex, not over here, but you should just know in distal radio-ulnar joint, there it has been formed between there is a ulnar notch, there is a ulnar head, and there is an articular disc. Fine. Now the ligaments. Now as I told you, there is a dorsal palmar, there's a dorsal as well as palmar radio ulnar ligaments are there. Now what is happening is in supination. Now in supination, the palmar radio ulnar ligament is taut, and the dorsal radio ligament is laxed, whereas in neutral position, the articular surface of the head of the ulna has maximum contact with the radial articular surface. This is the neutral position. Okay? So there is no action taking place between the palmar and the distal. Whereas in supination, the palmar side of the radioulnar ligament will be getting taut, whereas in pronation, the dorsal radioulnar ligament is getting taut. Fine. And the muscles, you know that they are basically the pronator teres and quadratus and biceps and supinator muscles. Now I wanted to show it in figure. Now if this is the diagram, you can see the A diagram, wherein you see that in A is for supination. You see that the dorsal radioulnar ligament is laxed, whereas the palmar radioulnar ligament is taut. In the C diagram, you see is the palmar radioulnar ligament is slacked or laxed, and the dorsal radioulnar ligament is taut. So B is the neutral position of the, or the normal position of the the inferior radioulnar joint. Now the axis of motion. Now let's come. This is all the anatomy, articular surface and everything. Okay, and now let us see the main part which we are studying is the kinematics. Now again, the axis. Whenever we start with the kinematics, we have to tell the axis of motion. Now the axis of motion of pronation and supination is this, if I can tell you, is it is arising from the radial head. This is the radial head. It is arising from the radial head center of the radial head above and center of the ulnar head below. So the axis is running, you can see, from here obliquely till the ulnar head. It is arising from the center of, it's an oblique axis. How it is going? Because there is a rotational movement which is happening. Okay? It's a vertical axis and transverse plane motion is taking place. The axis is from the head of the radius above and the head of the ulna below. Okay? So this is an oblique axis. The axis of motion of pronation and supination is longitudinal axis extending from the center of the radial head to the center of the ulnar head below. Fine. In supination, now basically in supination, the radius and ulnar are parallel to each other. They remain like this only. This is a supinated position. How I am holding this. This is said to be the supinated position. The radius and ulnar lying parallel to one another. Whereas in pronation, what happens is the radius crosses over the ulna. The radius will cross over the ulna. There will be movement of radius which will be happening. The ulna will not move. Fine. The motion of the proximal ulna is the proximal part of the ulna is negligible. Whereas the motion of the distal part of the ulna is little bit is there, and we will talk about it. Fine. But mostly the movement is taking place is that of the radius. And that of the radius. So the ulna will be moving opposite to that of the radius. Fine. So what is happening is that in pronation, the movement will be first pronation, because in supination the bones are similar to this position. Now what happens is in cases of in pronation, the radius will move ahead of ulna. The radius will move ahead of ulna. So that means the radius is moving anteriorly. The radius is moving anteriorly. So the distal end of the, if you can see, the radius is moving anteriorly. Little bit. I am showing it so that it is much appreciated, but the movement is not like this. Fine. It is crossing. The ulna, basically the radius is crossing over ulna. So the movement, in order to control this movement, the ulna will move distally. The ulna moves distally because the radius is moving proximally. Fine. This is happening over here. Now what happens in supination is the radius will go back to its position and the ulna will move proximally and medially so that it secures its position. So this what happens in pronation. In pronation, the radial head is, or the radius moves the radius moves in the, or crosses over the ulna. It basically crosses over the ulna, so the ulna moves distally. And what happens in supination is the ulna comes back proximally and medially. The ulna comes back proximally and medially and secures the parallel position of the both bones. Fine. Now supination is 90 degree and pronation is 80 degree. It is little less, supination is more as compared to the pronation. The total range is only 150 degree. When the elbow is in flexion, now this is very important, when the shoulder elbow is in extension, there will be a shoulder rotation component will come. So we have to take it as when the elbow is flexed to 190 degree, then only the pronation and supination range need to be taken care of. There is certain factors which limit the motion, so you should know about them. That means that is called as pronation limitation. So the first movement we always tell about in proximal and distal radial ulnar joint motion is, because the motion is combined, whether it's in proximal or whether it is distal, the motion is almost combined because the motion is only pronation and supination. So fine. So the axis is oblique, so the movement is taking place of the radius moving ahead of or the radius crossing the ulna. So now whenever the elbow is this motion takes place, so what all muscles limit the pronation movement? So one is the elbow biceps muscle. Biceps muscle comes into action. Why so? Because the elbow is extended by biceps muscle. So the biceps play a very crucial role in limiting the pronation movement. Fine. And because though it is a supinator, but it limits the pronators. That means the elbow position is very much important. 90-90 holding position is very much important. That means also the tension of dorsal radio-ulnar ligament that will be taut, and the posterior fiber of medial collateral ligaments. They all are bringing about the stability or limiting the pronation movement. So the stabilizers are the posterior fibers of the medial collateral ligament, and the tension is on the dorsal radio-ulnar ligament. Fine. In supination, there is a tension at the palmar radio-ulnar ligament and the oblique cord muscle or oblique cord ligament. Fine, you understand? Now guys, I have made kinetics and the kinematic table for shoulder complex. You have seen in SC joint. Now later on, I am not making that table. I have already given you all the material in my PPTs. You have to make your own table, because if you have made table of each and every joint, it will be very easy for you to understand and explain in exams. So I'm already covering everything over here with the factors limiting, what is osteokinematics, what is arthrokinematics, what is a type of motion. So you need to tell me about the motion, that is osteo motion, that is herein you are telling me about the pronation and the supination, the range. Then you have to tell me, in which axis and which plane it is happening, what kind of a joint it is, you can mention over here. Then which are the muscles which are responsible for this movement, what is the arthrokinematics of this movement, you have to tell me. And you have to also tell me about the factors which limit the motion, or the stabilizing factors which control the movement. So these are the heading. You have to prepare it yourself. The material is, everything is given in my lectures. You have to prepare your own, and you have to write it yourself. Fine. And you have to need to submit me also the way I have shown you in the SC joint. So you have to submit me for the motions of kinetics and kinematics of scapulohumeral rhythm. You have to tell me about that. Then you have to tell me about elbow and radio-ulnar joint also. You have to submit me those kinetics and the kinematics of these joints. This is your homework. For every joint I am completing, you have to give me the chart. It is in the form of chart. You need to tell me, because everything will be covered here. Now the next is the role of the muscles. I will not be discussing it, but you all guys know the pronator teres and pronator quadratus, they both work. They are mobility muscles as well as dynamic stabilizers also. So they stabilize the proximal radio-ulnar joint, as well as they resist also, or they produce pronators. They are pure pronators but are also assessed in elbow flexion. So the pronator teres also helps in elbow flexion. Now supinators, they basically work for the supination, generating for the supinator and biceps. They both work when the elbow is flexed to 90 degree. The supinators as well as elbow flexors, they work together, and along with the enconeus. Now going to the arthrokinematic movements. Now you understand that you understand that the proximal and the distal, you see the proximal and the distal, herein the convex head and the convex radial head, convex ulnar head is basically moving. It is basically what is happening is there is a in the proximal radio-ulnar joint, if you can see the convex, well, let us see first this one. Convex radial head is moving on a concave radial notch. This was a concave radial notch, this was a convex head. So this is moving on the concave, that is concave is the stable articular surface, and the moving articular surface is convex. Herein convex structure, so the arthrokinematics is opposite to that of the osteokinematics. So in pronation, what is happening is the movement is going, that is the radius is moving ahead. The radius is moving ahead. So what is happening over here is the head is moving anteriorly. You see the radius is moving ahead. In pronation, the head is moving anteriorly, but the glide is taking place posteriorly. Okay? So the head, the pronation is when the radial head, because the motion takes place at the radial side, no motion takes place at the superior, at the ulnar side. We have seen that there is no motion which is happening on the ulnar side, but the motion takes place only at the radial side. So what we see is the radius is moving anteriorly. What is pronation movement? The head of the radius is moving anteriorly. Or if you can see this is a pronation, where the pronation is said to be when the head is, the radial head, can you see this movement? The radial head is moving anteriorly. The head is moving anteriorly. So herein the head is moving anteriorly. The head is moving, repeating it again, the head is moving anteriorly. So the gliding is taking place posteriorly. Showing you in this position the elbow. This is the midway between the supination and pronation. You can see the sum, the radius point, you can place it. The head of the radius is moving anteriorly. So the gliding is taking place posteriorly. Now what is happening in supination? Now the head of the radius is moving posteriorly and the gliding is taking place anteriorly. Fine. This is happening at the proximal radio-ulnar joint. This is happening at the proximal radio-ulnar joint. Now what is happening at the distal radio-ulnar joint is, you see this, that the radius, this is called as the ulnar notch. The ulnar notch is concave, whereas the ulnar, the articular surface of the ulna is convex. Okay? So this is basically the ulnar notch of the radius is concave, whereas the articular surface of the ulna is convex. But the motion is, the irony is, the motion is taking place by the concave surface. The here radius is moving. That means the convex surface is stable surface and the moving surface is concave. So arthrokinematics will be same as the osteokinematics. That means in pronation, when I have to see the distal part, in pronation, if we see this, the radius is moving anteriorly and the gliding is also taking, rolling is taking anteriorly and gliding is also taking anteriorly. Whereas in supination, the radius is moving posteriorly, rolling is posterior and the gliding is also posterior. Fine. This is a very important part you have to tell over there. Now, what are the stability muscles? Stability is always provided by the muscles. So the muscle supports at the distal radio-ulnar joint is the pronator quadratus, which is a dynamic stabilizer, and extensor carpi communicus, that is extensor carpi ulnaris tendon, which plays a very crucial role in this. And mobility. Now in mobility, the functional position, you should know the functional position. The range, you understand, it is supination is 90 degree, pronation is 80 degree, 150 degree range is there. In elbow flexion is 145 degree. But you need to understand what is the functional, for functional activity, what range should be there. The range should be for elbow flexion should be between 30 to 130. The range should be between 30 to 130. It is not that it is 100 degree. We say between 30 to 130. And the pronation should be 50 degree of pronation and 50 degree of supination. This is the functional range which is required for us to do any of the ADLs, that is eating, brushing, hair, teeth, brushing and dressing ourselves. We require this much range. But if the person is operating on a telephone, now we don't hardly do it. But when we are holding the mobile phones or anything, we require 40 degree of pronation and 20 degree of supination. So you need to keep in mind what kind of activity the person is doing before you think about the functional range. Fine. So there is effect of age also, which affects the range of these motion, and the effect of injury, and this is very important. Now we have got there are compressional forces which are acting on the elbow, and because of that there is the nerve gets really compressed over here. Like compressional forces can be because of the bony fracture or because of dislocation. So there is chances of getting compressional forces along with the at elbow is very high. So one need to take care of these strains at the elbow. Fine. These compressional forces may result in carpal tunnel syndrome. Now what will happen is the ulnar nerve will be getting compressed, that is the flexor carpi ulnaris muscles is getting compressed, and it further compress the ulnar muscles, and you find the tingling and numbness sensation on the fourth and the fifth finger. Fine. So ulnar compression can take place at the cubital tunnel syndrome because of that fracture or because of the entrapment of the nerve. And there can be a distractional injuries, that is in pulled elbow, which we see in young children, less than 5 years of age. When we try to lift the child, we basically pull the elbow. That's why it is also known as nursemaid's elbow. In this condition also, the head is pulled out of this annular ligament. The head is dislocated of the head of the radius is dislocated out of the annular ligament. So there is other injuries also which we need to be taken care of, that is the varus and the valgus injuries, and which is medial epicondylitis and lateral epicondylitis. We also know about it, tennis elbow and golfer's elbow. We are all aware about it. Fine. So I wind up this elbow joint with this lecture. And I have in this lecture added these injuries, though I skipped in shoulder joint the injuries all related to shoulder, because it was vast, and we are doing is you are assessing the patients in the OPD. You are already aware of it. But if you want to add, you can add those, and you have already studied about it. So that I tried to skip those in shoulder joint, but I have added it in elbow because it gives you an in-depth. These are the common injuries which are there in the elbow joint, because it was easy for me to mention also. There were only 4 and 5. In shoulder it was so vast that it could have taken me another 2 lectures to cover those injuries. Fine. So I hope you have understood the elbow joint and the elbow complex, the biomechanics or the motion taking place at elbow and superior radio and inferior radio ulnar joint. Okay, and I hope if you have any doubts, you can put that in the comment section or personally WhatsApp me. Thank you very much.